Hello, everyone. Thank you for coming. Welcome. This is the first or inaugural speaker of the Institute for Addiction Science speaker series. And for those of you guys who don't know much about the Institute for Addiction Science, or IAS, we're a new collaborative institute. And what we're trying to do is we're trying to bring together researchers from across 6+ schools scattered on the 2 campuses of the USC who share a common interest in addiction research. And as part of this, we're trying to develop an intellectual community that's ripe for collaboration and education. And one of our goals is to bring in outstanding speakers in order to achieve that aim. And we're very, very pleased and excited to have as our first speaker Dr. Steve Higgins. And just a little bit of a background about Dr. Higgins. I think that most people here are familiar with his work. One of the things that I thought was interesting when I perused his CV is that he actually has a degree in developmental child psychology. And I didn't know that he had kind of roots in developmental psych. Of course, addiction is the developmental disorder. But from there, Steve trained at the Johns Hopkins Behavioral Pharmacology Research Institute, and then went to NIDA for a bit, and then has been at University of Vermont ever since. And he is really very, very well known, one of the highest impact researchers in all of addiction. He's well known for developing parallel programs of research in behavioral pharmacology in the lab, treatment research, treatment development research, and more recently, this decade, policy research. And some of his major contributions have been in the area of behavioral economics. And I think you'll see probably that will shine through that although Steve is a highly interdisciplinary researcher and works in a lot of different areas, I see that most of his work is motivated by a common underlying theory in behavioral economics. He's been doing it for a long time, far before it's caught in favor more recently in medicine, more broadly in prevention. Steve's been doing this stuff. He's won many awards, some of the biggest awards that you can get, like at the College of Problems Drug Dependence, Senior Research Award, American Psychological Association Division on Substance Abuse and Psychopharmacology, more than 300 papers, a lot of them are very high impact, probably more than $100 million worth of grants, and just a really cool guy too. So we're really excited to have Dr. Steve Higgins from the University of Vermont.
Thanks for that generous introduction, Adam, and it's a real pleasure. I know of the USC Tobacco Regulatory Science Group because our university has a branch in that same area, so we know each other. But I had never been to USC, so it's a blast to be here. I've had a beautiful morning. As you can see, I'm at the University of Vermont, so last night when I left to come here, it was snowing. I was in a snowstorm, so the weather was beautiful, and so I'm really thrilled to be here. Thanks for inviting me in.
Sure.
All right, so I'm going to, you see what I'm going to be talking about. I'm going to try and, I like to look at my slides, but if I'm getting too far from the mic, just please raise your hand. So I'm going to talk about changing drug use and other health-related behavior in those with substance use disorders. So all of the work that I'm going to be doing or be presenting today requires teams. So I've been very fortunate throughout my career to have excellent faculty, collaborators, pre-docs and postdoctoral trainees, research staff, and general research support, and I have no conflicts of interest to report. So I have the good fortune of directing the Vermont Center on Behavior and Health, and so we research relationships between personal behavior, lifestyle, and risk for chronic disease and premature death. And substance use, cigarette smoking, is a big part of this, but not the only area that we research. And we're interested in both mechanisms that underpin risk for unhealthy lifestyles, but also interventions to promote healthy behavior change. So I'm going to focus mostly today on the interventions and treatment development. A common thread, as Adam was mentioning, is our research, a common thread across our research product is the application of concepts and methods of behavior analysis, behavioral economics, behavioral pharmacology, and especially leveraging the reinforcement process to promote behavior change. That's a process that underpins much of these unhealthy lifestyle patterns and the difficulty of changing them. And one of the things that we'd spend a lot of time looking at is the efficacy and cost effectiveness of financial incentives and other reinforcement-based interventions in promoting health-related behavior change. I'm going to spend, that's a long-standing interest of mine and my colleagues, and I'm going to spend a good amount of time talking about that this morning and a little bit of additional work having to do with the current opioid epidemic. All right. So I began my work in this area back in the preceding U.S. drug epidemic, and it was the cocaine epidemic of the 1980s and 1990s. And some of you probably remember that, but a lot of you may not. You may not have been paying attention to those kinds of things at that time. But there was a cocaine epidemic much like the current opioid epidemic. The scientific and clinical community was caught totally unprepared. I mean, at least with the opioid epidemic, we know that methadone and buprenorphine therapy are a big part of trying to treat that problem. With cocaine, we didn't even think it was addictive. People were singing songs about how great a drug it was, and it didn't produce problems, so that was wrong. The behavioral and pharmacological treatments that people initially tried with the problem just failed miserably. And so you would pick up a journal to see what was going on, and it was not encouraging. And so the National Institute on Drug Abuse was putting out calls for proposals on treatments. And as you looked at least my colleagues and I, when we looked at the pharmacology of cocaine, we didn't think it was likely that you were going to develop an effective pharmacological treatment that was also specific, because the drug acted very much through dopamine and was likely to impact normal functioning if it was strong enough to impact cocaine use. And it's still the case today that no one has yet really solved that challenge. There's no efficacious pharmacotherapy for cocaine dependence at this point. So we went in a different direction. I'm going to share that with you in a few minutes. But in terms of relevance of this topic, that cocaine and amphetamine, well, first of all, this high problem of cocaine and amphetamine addiction never went away. It just got less attention as years went on. But it's actually starting to make a resurgence in the context of this opioid addiction epidemic, and people who work in methadone and buprenorphine clinics are now reporting that there is an emerging problem with people using these psychomotor stimulants. So when I started putting my slides together for this presentation, I got an email from one of my colleagues about this new meta-analysis that just came out. And I didn't even know that there was a plus medicine. So that was new to me. And then it was on a topic that's of interest, this comparative efficacy and acceptability of psychosocial treatments for cocaine dependence, because we had spent about 20 years researching that topic, but it moved on to other things more recently. And so I had a look at it, and what they did was, and let me say something about who they are. These are evidence evidence-based medicine researchers. They're interested in evidence-based psychiatry in particular, and they're at Oxford. And so much of this work was done in the United States, so they're kind of an independent party to having a look from afar. And their specialty is in these meta-analyses and not really in cocaine addiction. And I thought that was a breath of fresh air, is just to see how that group would look at this and approach it. So they were able to identify 50 randomized controlled trials and almost 7,000 participants in these trials. And they were comparing structured psychosocial treatments versus either another structured treatment or treatment as usual. And regarding the treatment as usual, about 5,000 were in one of these structured treatments and almost 2,000 in the treatment as usual. So that's a pretty interesting data set. And then the reason that they're focused on the psychosocial treatments is because without an effective pharmacotherapy, the clinical guidelines are suggesting that you should offer a psychosocial treatment, and they were saying, well, there's a bunch of them out there, which psychosocial treatment should you offer? So these are likely to be unfamiliar to some of you, but familiar to those who follow cocaine research, cognitive behavior therapy, contingency management, community reinforcement approach, and then a number of different treatments. So 12 different psychosocial interventions and their combinations. They had some minimal criteria. The treatment had to be at least 4 weeks. And these were the outcomes. They wanted more objective outcomes, biochemically verified abstinence, how well people were retained in treatment. So they were being fairly hard-nosed about it. So here's the thing. I apologize. It's going to be hard for you to see all this, but there was no better graph for me to copy out of their review. So this is a forest plot. And what they're doing is they're going to compare these different interventions against treatment as usual. And if the odds ratio here and the confidence interval doesn't overlap with this line, then it's significantly different than treatment as usual. And the thing that jumped out at us, and the reason we were so excited about it, is that the treatment that we developed, and I'm going to tell you about, this contingency management in combination with the community reinforcement approach, was the only intervention that differed from treatment as usual across every endpoint that they were looking at. And so this first one is what the odds of abstinence at 12 weeks into the treatment. And then this one was the odds of abstinence at the end of the treatment, and then this was the odds of abstinence at the longest follow-up that was included in the study, or in this model. And then this is, could you retain people for 12 weeks, and could you retain people for the recommended duration, whatever that was for the intervention. So this treatment is something that we spent a lot of time developing, but it's something we, as I mentioned, we had moved on. So I was thinking about you guys in a new addiction center, and I thought some of you must be involved in treatment development research. So when I saw the review, I thought I should spend a little time on it, because even though some of that research is going to be old research, this meta-analysis that came out less than 2 weeks ago is saying this is the best we have at this point. That doesn't mean it's anything like a silver bullet, but it'd be a place that if you're challenged with disorder, or as I'll show you, if you're trying to make a contribution, as I know at least one or more of your colleagues are, to developing treatments for the opioid use disorders, this treatment can be very helpful and might be a good place to start or have a look at. A good treatment to have a look at. So for one thing, there's a structured, standardized therapist manual that's available free on the website of the National Institute on Drug Abuse. And so this is back from when we were battling the cocaine epidemic. It got put up there, and it's still up there. And so if you're interested, you can have a look at it. I'll just give you a feel for the general treatment structure what we were trying to get at, and then some of the studies that we did on it. So when someone presented for treatment with us, we recommended that they would be with us for 1 year. The formal treatment was 24 weeks, and then it was fairly intensive early on, and then we tapered the intensity. So we recommend that they come for twice weekly counseling using this community reinforcement approach, which was actually initially developed for alcoholism. We adapted it for cocaine. And the theme, what you're trying to achieve with this counseling approach is to try and teach people how to derive reinforcement from the community for healthy lifestyle choices rather than through drugs. Because the mechanism by which drugs drive repeated use of addiction is reinforcement, but it's not the only source of reinforcement. But there are some individuals who have deficits in how you can access reinforcement in a healthy way. And then we did regular urinalysis that would allow us to detect any cocaine use by 3 times, Monday, Wednesday, and Friday. And then we introduced this, what's now in the addiction field very well known, voucher-based contingency management, but this was the first time that was developed and introduced. And so if someone showed us through urinalysis that they hadn't used cocaine recently, we gave them these vouchers that are exchangeable for retail items, and I'll give you more information on that in a second. Then the incentives ended after 12 weeks, and then we continued the counseling once weekly, the voucher-based incentives, once weekly counseling in the second half of the 24-week treatment period, start decreasing the frequency of urinalysis. But if someone showed us that they had used, now we're just giving them a $1 lottery ticket rather than these vouchers. So we're kind of tapering the intervention across the board. And then at the end of 24 weeks, we recommended that they at least check in with their therapist once a month to see how things are going. Okay, so just quickly on this voucher-based incentive program, if you showed us through your urine tox test that you hadn't used recently, you would earn these points that were recorded on vouchers, just slips of paper. And they had monetary value, purchasing power, but because it was cocaine and people used to snort cocaine through dollar bills and whatnot, so money was actually a discriminative stimulus for using the drug, we never gave them cash. And so that was the reason that we went to this voucher. And so we started at a low value, and then each time they showed us that they haven't used, the value of the incentive that they would earn would increase. And then if they showed us that they could go a whole week without having used cocaine, they would get like a special bonus, so another incentive. So we're just trying to, cocaine users often use it in a binge fashion, and if they present it for treatment when they're coming off the binge, you might have a week or two before they're going back, and we're going to try and reinforce the heck out of not using, so when the next binge time rolls around, maybe they have second thoughts about using. And then if you had a cocaine positive test, then you had to go back to the beginning on the cocaine, on the incentive value. So we're trying to build up that they would be invested in sustaining abstinence. In somewhat technical terms, what we're trying to do is differentially reinforce periods of continuous abstinence. That's the goal of drug use treatment. And so if they sustained abstinence throughout that 12-week voucher period, they could earn just shy of $1,000. And so when we first mentioned this, the reaction of people was, you got to be crazy to think you could get a cocaine addict to abstain from this. They're like selling their houses, ruining their marriage. This is a phase. This isn't going to work. Of course, as soon as it works, then they tell you it's way too expensive to use. But that's all right, so the CRA counseling, I already mentioned that the whole idea is to try and teach them how to get reinforcement from healthier sources, but there are more technical, like 5 different things we attended to. You know, the antecedents, how to avoid the antecedents of cocaine, find alternative to drug use to have positive consequences, make explicit negative, learn how to recreate without drugs involved. So this is pretty intensive, trying to get their lives structured in a way. We assume that everybody's vulnerable to enjoying drug use. What keeps the rest of us from getting deeply involved like this? And it's these kinds of reinforcers. You got a job that's inconsistent with being hungover, from using cocaine the night before, and that sort of thing. So we're trying to get these things set up in the cocaine user's life, and we have ways that structured, validated ways called the Job Club to help unemployed people get jobs. If they have romantic partners who weren't cocaine users, we would try and get the romantic partner involved and teach he or she how to reinforce abstinence. If they had an alcohol use disorder, we used a drug called disulfiram therapy. I could give a whole lecture on what that's all about. The long and short is disulfiram therapy is an old medication that's been around for alcohol problems. It essentially makes you sick if you drink while you're taking the medication, just because it interferes with the metabolism of alcohol. But the reason we were using it with these guys is about a large proportion, the majority of cocaine-dependent individuals survive for treatment, also alcohol-dependent. And for many of them, even those who aren't dependent, alcohol will set the occasion for cocaine use. And so they use other drugs, for example, marijuana, but we could then document no functional relationship between marijuana use and the likelihood of using cocaine, so we ignored that in the treatment. We only focused on those things that we thought had a functional relationship to the likelihood of using cocaine use. All right, so we did 7 controlled clinical trials looking at different aspects of this treatment, and lots of clinical lab studies to ask questions about cocaine use or how some element in the treatment worked, where we started substituting cigarette smoking for cocaine use, and that actually set us up for some other studies that I'll tell you about. But initially, we were just doing that as a convenience. Cigarette smoking is legal. It is a form of drug self-administration. We think that there's enough commonality across drugs that you could learn things that are relevant to cocaine from studying cigarettes. And I think that is true, and I'll show you some evidence of that. All right, so we did 2 clinical trials that compared this treatment package, if you will, versus what's already available in the community. And then we did the standard care or treatment as usual. Then we did 4 experiments isolating the effects of the incentive program on being able to abstain from cocaine, and then 1 that isolated the effects of the community reinforcement counseling. And so I'm going to take you through a sample of those studies. So the first one was just a relatively straightforward thing, that we have this new treatment package. Can it do anything better than what's being offered already in most communities, and I'm sure in this community? And so we compared it against a counseling approach that's professionally delivered, but it's based on a disease model and incorporates a lot of the concepts of AA and NA 12 steps. We took 38 cocaine-dependent, or I should say, we got experts in this model to deliver that, and then we got experts in behavior therapy to deliver this one. We took 38 people who were dependent, and we randomized them to get one of those 2 treatments, and we did 6 months of treatment, 6 months of follow-up. So here's what we found. This is weeks of treatment, % of subjects who were abstinent from cocaine, biochemically verified. This is the new treatment, and this is the standard treatment. This is what was in the literature at this time for treating cocaine dependence in an outpatient clinic. You see them initially, and then quickly stop coming or resume cocaine use. And this was completely unexpected. And it was fun because we didn't even know what we had. Like, we weren't sure, but we thought it was kind of good. And so we took this to this conference that Adam mentioned, this CPDD, College of Problems Drug Dependence. And there was a symposium in which, or a paper session in which this was like the norm. And then we had this, and it just was the big, like, whoa, how do you get that? This is crazy. They don't have real addicts in Vermont. That's the only reason it is. A lot of fun. So the question, what's the key contributor? What do you get? you're throwing a package at them. So the first one that was easy to separate out is this incentive program. And so we did a trial that appeared then it was Archives of General Psychiatry, now it's John Psychiatry. And we randomized people to either get the CRA plus vouchers the way I was just describing it to you, or only the CRA counseling. That's easy to find out. The question, what's this incentive program have to do with it? And this is what's the average amount of continuous cocaine absence you could achieve in a recommended 24-week period if you gave them the whole thing or if you just gave them the CRA counseling, and it doubled. And so it was like a definitive question in a clinical trial, like, yeah, the incentives are playing a big part. And that's what people assume, but that's not quite what the meta-analysis shows. It's the only intervention that is getting those long-term follow-ups is the CRA plus the vouchers, or the vouchers plus the CRA. So anyhow, the way the science progressed was these incentives were playing a big part. So if you then looked in the first 12 weeks when they were available, it was making a contribution then, but it was also making a contribution later in the second half. Because remember, the voucher incentives ended right here. So that was reassuring. And so then the next challenge is, are you getting the longer term effects? Is there any evidence that you can impact use longer term? So there we did another clinical trial, published it in APA journal, American Psychological Association, called JCCP, Journal of Consulting Clinical Psych. So now what we're going to do is everybody is going to get the CRA treatment. Everybody is going to get the vouchers. And the only difference is a contingency. That in one group, during those first 12 weeks, when they get in order to get the vouchers, they have to show us they haven't used cocaine. In the other group, they will get the vouchers, but independent of whether they use cocaine. So the only thing we are manipulating in these patients is that contingency in the first 12 weeks. And we're going to follow them during the treatment and then 1 year out beyond that. So this is, again, this mean duration of continuous abstinence. And so these two groups are being treated very similarly, almost identically, but you can still see pretty significant differences in how well they could sustain cocaine abstinence. So if you look at 12 weeks, during the 24-week treatment period, you're getting more than a twofold difference here. All right. Then when we follow them up, this is 6 through 18 months, so 1 year after treatment, this is what we call point prevalence abstinence, and this is the group that had the contingency, and this is the group that got the vouchers independent of the contingency only during the first 12 weeks. And every time we look, the point prevalence absence was higher in the group that got the contingency compared to the group that did not. So this is point prevalence, this is continuous abstinence, and both ways you looked at it, that contingency on just that feature of the treatment made it a substantial difference. All right, so now is the CRA active? And we did another randomized trial, 100 people, and what we're going to do here is half of them are to get the full treatment CRA plus vouchers, and the other group's just going to get vouchers only. And then we looked at drug use and psychosocial functioning, and I have to admit that I didn't even have a full copy of this paper available as I slapped these slides together, because I wasn't planning on going into this. If I did, it was only seeing that meta-analysis that made me think I should spend some time on this treatment. So what I can tell you is from the abstract, or what I'm summarizing here, where we delineated what significant effects there were. So if you got the CRA plus the vouchers treatment, that's significantly greater treatment retention. So that means CRA is important to that. Those who got the full treatment use cocaine at lower frequency, not the continuous absence, but the number of instances of cocaine use lower frequency during treatment but not follow-up, lower frequency of drinking. Remember, we spent a lot of time to solve for them, that sort of thing. Lower frequency of drinking to intoxication during treatment and follow-up compared to those who just got the vouchers only. And then the psychosocial functioning, I think, is even more important. If you got the full treatment, you have higher frequency of days of paid employment during treatment, the initial 6 months. Remember, we're doing job club. Decreased depressive symptoms during treatment only. And then most importantly, I think, fewer hospitalizations and legal problems during follow-up throughout the 1 year compared to the vouchers only. So when these guys, I just want to underscore, they aren't us, like, you know, when you're at this point that you're in the clinic for cocaine, it isn't like you drank too much, like you drank 5 beers instead of 3 beers, or you did a line of cocaine when you shouldn't have, or something. They get themselves in really serious situations. And they end up in a hospital, and they end up in prison, that sort of thing. So having the CRA treatment was doing, combined with the incentives, was doing some important things to keep these guys safe and keep them out of the hospital, out of institutions, really. So I think both are important. So now, while this review in 2000, the last month of 2018, you saw the years in this, is saying both are important, the field largely went after this incentive program, including me. And the CRA kind of got left behind. Not, you know, obviously there were enough to do this meta-analysis, and investigators in Europe that were being hit with cocaine after the US did some of those trials over there, and we worked with them in Spain in particular. But anyhow, this CM, this voucher-based approach, really got a lot of research attention. And so we did reviews because we were interested. We came up with this idea. And so every few years we would look and do a review to see what was going on with this intervention in treating substance use disorders. Because it's used to treat some other kinds of problems as well. So we did one in the years, you could say, see here, and then that covered, I think, 13 years. But long and short, across these 3 reviews, the last one that came out in 2016, we covered 24 years of research. And so this is a forest plot from the first review. And the thing that jumped out at us is that people had extended it to a lot of other drugs. And it was working with all of them. You could get abstinence from a wide variety of drugs. Remember, I was mentioning that we would do little studies on nicotine, figure, well, what we could learn with cigarette smoking would teach us something about cocaine. And I think we're right. And this shows you take what worked with cocaine, and you could get control over a wide variety of different abused drugs. And so in this plot, remember, if it doesn't overlap with 0, you're getting a statistically significant improvement in the odds of abstaining. And the only one that overlapped with 0 was alcohol, because there was only a single study, and so it was a variance estimate was large. All right, so across the 24 years, there were 176 control studies published in peer-reviewed journals looking at some variation of that voucher-based incentive program, and 151, or 86%, report statistically significant treatment effects. For dealing with a problem like substance use, that is a heck of a lot of evidence supporting its efficacy. So if those interested in treatment development, that's an important thing to keep in mind. All right, so the other thing that I just wanted to mention is we had no idea that this opioid epidemic was going to happen. But there were 3 investigators at the University of Vermont who were working on addictions, and we worked together across the drugs of abuse, but we chopped the world up by drug abuse. So John Hughes, he was the primary guy on tobacco, I was the cocaine guy, and Warren Bickle was the opioid guy. And so we looked at the same CRA vouchers treatment for opioid use disorder in the context of what we call an extended detoxification using buprenorphine. And I won't go into details, but it worked beautifully. So I think, again, I know at least one of your colleagues is wrestling with treatment development for the opioid use epidemic, and I think this treatment potentially could. All right, so I was among the crowd that just went after the vouchers and left CRA behind, which I feel a little sad about, truthfully, because it's a great treatment, and it's actually also a good treatment without the vouchers, just CRA counseling. It's very good for adolescents as well, and there's been a lot of trials. That's one area where people kept running with CRA during the 2000s, and there's some good evidence supporting its efficacy with adolescents with drug use problems. So I went in the direction of what's another population where people are really struggling to get any control over their behavior, like was the case with the cocaine users. And so pregnant cigarette smokers, which at first, if you don't know the population, you might think, wow, that would sound like a much easier population to work with than illicit cocaine abusers, but not the case. They are very difficult to get to quit. So I'll show you, tell you a little bit about that. So it's a serious public health problem. It's the leading preventable cause of poor pregnancy outcomes in developed countries. And in the U.S., about 22% of U.S. women of childbearing age are regular smokers, and about 13% of pregnant women are smokers. Hugely influenced by socioeconomic class. I'm sure there aren't many cigarette smokers. There might be one, but there are not many cigarette smokers in this group, highly educated group. But if you look at people with a GED, it might be more than 40%. So if a smoker, they're more likely to be disadvantaged anyhow to be a smoker, but about 1/3 of smokers, as soon as they find out that they're pregnant, and we've actually looked at how quickly they quit. They put down their cigarettes almost as soon as they get their pregnancy results, and they're very good at sustaining abstinence through the pregnancy and early postpartum. But there's 2/3 of them who keep right on smoking. And they're the ones that you really have to try and do something for. So people have been trying. The first controlled study was reported in 1984 in JAMA. And so it was a very nice study, first controlled study on this problem, smoking during pregnancy. And they did a very intensive multi-component treatment, sort of like what we did with cocaine. Let's throw everything at them. They had counseling, nurse home visits, educational materials, follow-up calls, and they got a very nice treatment effect. They cut overall for the entire group smoking by half, and they increased the mean birth weight by not insignificant amount compared to the usual care control group. So this set the field up beautifully to do something good on this problem, except all the subsequent research didn't do this. They went with very brief interventions, low-cost interventions. Let's get things that can be done when they come for their obstetrical care, their prenatal care. And the treatments, they have terrible effects. They don't work very well at all. And less than 10% of the trials report a significant treatment effect at the trial level, and only one of the trials that was done subsequent to this one impacted birth outcomes. So there's a group in Australia that does periodic reviews on this challenge, this problem, and what's being learned about how to decrease smoking in pregnant women. And every couple of years they do one. So they did one in these 2 times, and they both looked at 70 controlled trials, 25,000 women, and at a meta level, you could detect that the treatments, some pharmacological, some behavioral, different types, were producing an effect, but it was a relatively small magnitude. It could increase abstinence rate in late pregnancy by about 6%. So there was an exception. There was financial incentives. And instead of 6%, you were getting 24%, so 4-fold greater. And all it was is what I just told you about the cocaine-dependent population extended to the pregnant women, and you can change the outcome. So this is a meta-analysis of studies on that problem using financial incentives, and it was this Cahill et al. Did a Cochrane review on incentives for smoking cessation in the population generally, and they have a subsection that's specific to pregnant women, and that's where this figure is from. And so it's looking at the odds of being abstinent at the late end of pregnancy assessment. These are individual studies. These are 3 trials we did, and then other people are using the intervention as well. As you can see, not, some overlap with 0, but many of them not, and the overall change in odds is almost 4-fold increase in the odds of abstaining if you got the incentives versus some kind of control treatment. So what I'm going to do is take you quickly through how we do them at the University of Vermont. There's slight variations in how often they're given the incentives and whatnot. So this is a review that we published a few years ago where we reviewed how we treat this problem and what we were finding. So the results I'm going to show you are from 166 women, and most of them come from local obstetric practices or WIC programs in the greater Burlington area. Everything is from controlled trials. The majority is Vermont, so there's almost always a Caucasian population, maybe 93-4%. Relatively young, unemployed, no health insurance, less than or equal to 12 years of education. So we've actually compared the socio-demographics of this population against our cocaine-using population, and they are more disadvantaged. So it's really smoking during pregnancy has really settled into a group that's very disadvantaged, and in a way it's a little sad. So the voucher condition, you'll know this from the cocaine. So this is that, remember that trial where everybody got incentives? It said in one group that you had to show us that you didn't use recently, in the other group you still got the incentive, but independent of your smoking status. So that's the basic design of the study. The objectively verified smoking status, we use that same escalating schedule with resets. If we pick up the women usually towards the end of the first trimester, and we follow them through the 3 months postpartum, and so the results, during that period, if they were absent throughout, they could earn almost $1,100 in purchasing power, but the results, because we don't get all of them, the results I'm going to show you were obtained for about $461 in incentives. And then whatever providers, obstetricians, primary care providers are doing in the way of trying to help the women quit, we just leave that alone. All right, so this is the late pregnancy smoking status. So in the contingent, non-contingent, you've got, in this set of data, a 5-fold difference in the percent of women who are abstaining from late pregnancy. And then we run it out through 12 weeks postpartum. As you get further away from delivery, women who had been absent are starting to resume smoking, but you still have a nice treatment effect. And in this study, even 3 months later, you can see a big difference. That doesn't always happen. We have a trial going now where it's a cost-effectiveness study, and we're doing it against usual care, and we aren't getting this large a difference. So I just think it's a real difference, but you have to have a large sample, and the estimate's going to vary around if you have a smaller sample to get an accurate estimate. But this part has not varied, so I showed you the Cochrane review, and I'll show you this. All right, moving to U.S. opioid epidemic. So our center's been involved in trying to respond to this. The epidemics don't start, they get publicity suddenly, but they don't start suddenly. So when we first got our center going and started our careers at the University of Vermont, there was no medication treatment for opioid dependence in the state. So if you were opioid dependent, and there were some, and we could tell it was growing, they would have to go to another state in order to be treated. And so they would go back and forth between the other states. They would commute daily for methadone, and we didn't have buprenorphine offered at that time. So we got that going in Vermont, and then as this started to, as the prevalence of opioid dependence started to grow, we assisted in trying to increase the availability of medication-assisted treatment. I should say, I don't know how many of you are familiar, but for opioid addiction, it's pretty much, among scientists, there's consensus you need to be doing an opioid substitution therapy. There's some small percentage of the population you can treat otherwise, but the safest assumption is you need to do methadone-assisted, or medication-assisted therapy. It's called MAT. And so Vermont and many other states, including rural states especially, but large states like California, where you have rural sections like Northern California, we're really trying to get medication-assisted treatment available. And so we've been working on that. We've been very active in developing a model called the Hub and Spoke Network, and I'm going to tell you more about it, that helps to expand this medication-assisted treatment. And yeah, I'm going to go into more details about that. And then we've been researching how to improve other challenges in this population. And the one that I'm going to zero in on is how to reduce unplanned pregnancies. And I'll say more, but it's not a good thing when a opioid-dependent woman gets pregnant, because then the fetus is exposed to the opioid addiction. All right, so I'm going to touch on 3 studies. The Hub and Spoke Care for opioid use disorder that Vermont developed and we're exporting to other states. They're in Vermont early on, still a little bit, but not so much. There are wait lists for treatment for opioid dependence. And so opioid-dependent individuals will not stop using if you put them on a wait list. And so it's almost unethical to do this in terms of the implications, but many states are unprepared, especially in these rural states. They don't know what to do, so somebody appears and asks for treatment. They get put on these wait lists. They might be on for months or years even. And that puts them at great risk for infectious disease, overdose, crime. And so even as we tried to expand treatment, we also wanted to do something for these wait lists. And so that's what this study is going to be about. So you'll see. And then this is the study on the preventing pregnancies. All right, so what is the Hub and Spoke model? So Vermont was not unique, but in being impacted tremendously by this epidemic. And early in the 2000s, our governor, you may have heard about it, did a State of the State address in which he focused only on the opioid epidemic. And he said, this is the biggest thing going on in our state. And I think it was true for other states as well, but he was willing to stand up there and say it. And it led people in this state to start figuring out, what are we going to do about it? So the Commissioner of the Department of Health and the Medicaid office joined forces in putting this idea, with the input of the addiction experts in the state, of an integrated care model. And so the idea was that you would divide the state into these catchment areas, and within each area they'd have a central opioid treatment center. So we're actually borrowing this from other areas of medicine where you have hubs of expertise who can work with primary care doctors who are out in the spokes. And so in these centers, they would be experts in providing methadone, buprenorphine, sometimes naltrexone, not that often. They're going to be the hubs. And then each hub is connected to a network of medical providers who get, this is jargon a little bit, but they get a waiver. They undergo training to learn how to prescribe buprenorphine in a primary care setting. And so they're going to be the spokes. And what the theory, and we're actually putting it in practice, is a person comes in and they get referred to the hub for evaluation and initial stabilization on the medication-assisted therapy. And then the complex cases will remain in the hub, but those that are stabilized and seem to be doing pretty well, they get moved out into the spokes. But to reassure the doctors who aren't familiar with addiction and opioid addicts, we reassure them that if somebody destabilizes, they can come back to the hub. So it makes it more likely they'll go get the waiver and that they'll accept these patients. And so I'll show you how it's allowed us to dramatically increase treatment capacity. So this is a study that Brooklyn and Sigmund published, and just looking at 3 years in Vermont. And these are the different catchment areas, and across these 3 years, the census in the clinics. And you can just see this dramatic increase in each of these hubs in the number of patients being treated. And but yeah, so it's been a real success, and we're now trying to still fine tune it. We're trying to export it, and one of our colleagues is, like I mentioned several times, working with people in Northern California to use the same system. But during this period, there are people sitting on waiting lists in Vermont too. So Stacy Sigmund developed this method to effectively bring treatment to the people on the wait list. So she devised what we're calling an interim care protocol, and here, rather than have somebody on a wait list, you could see them once every 2 weeks, which wouldn't be too much demand on the clinic, in one of these hub clinics, the expert clinics. They take a dose of buprenorphine under observation in that clinic, and then they receive 2 weeks worth of medication, take-home doses, in this device that Stacy found. I don't know where she found it. It's in Sweden or something that it was first developed. But it was a secure device that allowed her to put a 2 weeks supply in there, and it's not easy to tamper with. Then she had additional safeguards where she would randomly call people back, and you had to bring your dispenser in there and show that you haven't been doing anything with it to undermine the idea of taking just 1 dose a day. And then she did a randomized efficacy trial. Just took 50 patients that were on a wait list and randomized them. Half would go into this interim treatment, or half would continue on the wait list. And the results were dramatic, and got published in New England Journal of Medicine. So this is the people that got the interim buprenorphine. These are the guys that remained on the wait list. This is participants who were abstinent from illicit opioids. So you can see, at intake when everybody was on the wait list, nobody's abstinent. You bring a medication and you get a dramatic increase up here. You're almost getting 100% abstinence. And the guys that continued on the wait list kept using illicit opioids. And then another way of looking at it is number of days of drug use in the past 30 days. Again, almost 30 when they're not getting any medication. Give these guys the medication, illicit opioid use drops dramatically. Leave them on a wait list, they keep right on using. And then number of days of intravenous use, which is really a risk for overdose and infectious disease. A lot of it when they're on the wait list, give these guys the medication and get dramatic reductions. All right, so the last study I want to cover here is what can you do about the unplanned pregnancies in this population. So this is just one, like an example of kind of major needs these populations often have. So about 45% of pregnancies in the U.S. overall are unplanned. And Sarah Heil, my colleague, leads this. So I didn't really know this, but apparently the unplanned pregnancies cost a lot more than planned pregnancies. pregnancies. So they're associated with problems. And it's estimated to be about 11 billion per year. When you look at the opioid population, whether they're in or out of treatment, 80% of them are not using contraceptives. Or 80% of them are, 80% of the pregnancies are unplanned. It's well documented. And there's the problem of the neonatal abstinence syndrome. So they have the unplanned pregnancy, they're opioid dependent, the infant gets pregnant, or the infant becomes dependent and often needs special treatment. So the cost of that is enormous, and this fellow Patrick estimated what those costs are. The goal of Sarah's work is just to get the women to use a medically effective and recommended contraceptive. Ideally, it would be a long-acting reversible contraceptive. And so she has a trial going now that's the evidence, enough evidence in is very compelling. So there's a usual care control condition, and what they do, these are, they come to the opioid substitution clinic to get their medication for their addiction, and they get told about contraception options and a referral to a local provider. What I skipped, and I should say, is the women were selected because they are currently sexually active, they are not planning to get pregnant, and they are not using a medically approved contraceptive. So that's like a bad combination. You don't want to get pregnant, you're sexually active, and you're not using a contraceptive. And so these guys come to the clinic, and the nurses talk to them and give them a referral. Getting the referral is more than is typically going on in clinics these days, but at least this would be, a reasonable thing to do. Then the World Health Organization has a protocol for how you can improve use of medically approved contraceptives. And what you can do is have them available on site at the time that you interact with the woman. You don't need to do a full physical exam. You can do a brief medical history, and apparently experts know how to do this. You can eliminate certain contraindications. If they're not present, you can start the woman right then. And so that's what this group gets. And then this group gets that same, these first two, well, this, plus they get incentives that during the follow-up period, which is going to be 6 months, they receive a voucher if they stop in and talk to the staff. Just take the time to talk to the staff about any side effects they're having with the contraceptive. The voucher is not for using a contraceptive. You could get this, you could not use one and still get your voucher, but just stopping and talking about what's going on with the contraceptive. All right? So just the referral out, the opportunity to get a contraceptive and to check in, but no incentive for checking in. And this group gets the opportunity to get a contraceptive at the clinic. And then also incentives if they're willing to check in with the staff, with the nurse, when they come about any side effects. And the max they could earn is $390 in incentives over 6 months. So the effects are pretty dramatic. So 6 months and 12 months, so 6 months that are mentioned in this is the follow-up period. You get these nice graded effects. So the proportion of women using a recommended contraceptive, 71% if you do the full package, 51% if you do the WHO and a World Health Organization intervention, and only 11% with usual care. And then if you verify the abstinence, I don't even know what the protocol is, but you can verify that they're using their contraceptive. You get the same functional relationship. Then this is the slide that I'll end on. It's really my favorite slide of the decade or something. This is pregnancies in the 6 month incidence pregnancy in the 6 months of the study. Usual care, 23% of these women are pregnant during the study. If you use the WHO, it goes down to 17%. Use the full protocol, 5%, almost a 5-fold difference, 4 to 5-fold difference by just incentivizing them to check in about side effects. All right, so there's, just to wrap up, robust support for CRA plus incentives and incentives alone for changing substance use disorders, reducing drug use, staying in treatment. The incentive-based models provide substantially better smoking cessation treatment on pregnant women than current clinical practices. We keep using these. We should be using the incentives, in my opinion. I think the evidence is there. Financial incentives have not been widely integrated into community substance use treatment clinics. Although there have been inroads made, the VA healthcare system is using them, and private sector employee wellness programs often use them. Vermont's making substantial headway in meeting treatment demand for the current opioid epidemic, and I think has potential to be helpful to other states. So our center would be happy to work with anyone in your center that's interested in this problem, trying to do something about it. And then last one is, I think us experts in substance use disorders should consider being stronger advocates for more evidence-based substance use disorder treatment and prevention interventions, because these are not minor things. People die by providing inadequate care unnecessarily, or get pregnant, or have pretty serious adverse life outcomes. And I think sometimes, and I include it, this is much speaking to myself as anyone knows, I think sometimes we're a little too soft on the policymakers about this. And the problem is, with other kind of health conditions, like HIV would be a great example, there are strong advocacy groups that will speak up on behalf of the patients. Illicit drug abusers in particular, but now that smoking has settled into the disadvantaged population, they don't have strong advocacy groups. So I think the only ones who are really going to advocate for them are us on this topic. So I'll wrap up there. Thanks.
Thank you.
Yeah.
Any questions?
Thanks for really fascinating talk. I was wondering if you could give your thoughts on what seems like a puzzle. What the psychology behind this puzzle is that, in some sense, if I'm a heavy cocaine user and I'm interested in quitting, contingent on me not using today, I will have a few $100s tomorrow. So that's contingencies there, and yet the data are very clear and impressive that a few dollars, equivalent of a few dollars or out ticket, makes a big difference. What do you think is the psychology that reconciles that?
Well, I think a couple things about it. So the one, I think, is a necessary condition that there are naturalistic contingencies in that person's life pushing them towards not using, trying to push them, have them seeking treatment. So spouses threatening to leave, just got fired from a job. So I think that's the background condition. And then I think factors that behavioral economists talk about, like salience, us saying you get this this incentive and this much if you can show us X. The savings that you get is not as salient, and I just think that that's an important factor. And the money probably, it is, the transaction is so discreet. So I think that's
part of our essay is, there are there's obvious resistance to paying people for successfully not using. And I'm just wondering if there's any potential for getting mileage out of some kind of instruction or app that helps them to frame, salient frame for their savings, do something with the money, I wonder if there's any way to get some mileage out of all that actual contingency that doesn't seem to drive behavior for psychology.
I think that's a good idea. I think you'd probably find a little bit in the literature on efforts in that regard, but nothing that's really developed. And then, you also have the issue of, once they're deep into this illicit drug use, it isn't always like a clear, okay, today I went and I go to my dealer and I lay out $50 and then I get this much cocaine. There's like, people are sharing, people are, you know, so more often than not they're paying out, but it's messy. And I think that's also probably a factor. So they you know, we might help them like, not make the transaction, save the 50, but they're still taking hits on someone else's crack pipe, which then, you know, interferes with self-regulatory processes. So, you know, it's that kind of stuff. And I think in this context of treatment, and like I hinted at a couple of times, all the experience I have, I would use the CRA and the incentives together. And I think it's in that context where you can get control with some of that stuff where you're not, it's not so transactional, you know. Yeah.
I'm curious if you, with the study populations, if you looked at motivation or did any kind of evaluation in relation to the level of readiness or motivation for people and how that impacted it. And then also, did you look at people who had co-occurring disorders? And is there any difference in that population utilizing this model?
Yeah. So I think we've done some of that. So let me speak to what I know. The pregnant cigarette smokers are striking in that the mean score is like on a 1 to 4 is like 3.99 in how much do you want to quit smoking. But the population is still smoking when they prevent for first prenatal care visit, just can't seem to get it done. And so I don't know that it's so much that they don't want to do it, but without the incentive, which somehow structures, they don't seem to get it done. And then some of them even with the incentive, because you know we're getting 35%, so the control group makes us look, and that's the usual care. It's awful. The usual care, like right now our community is as bad as the control data that I was showing you now. They make us look good, 35 versus 7%, but that means that there's 65% of them are still smoking. So yeah, so that much I know. We have looked at like plenty of times what predicts who's going to do well, say against the cocaine, in the cocaine population and whatnot, and it's often counterintuitive. People assume that it's going to be the most disadvantaged population. The only reason they're going to respond to the incentive is because they're so poor, just as a chance to get a couple extra dollars or something. But it's usually the opposite. People who are employed, people who have more education. So it's, once I reflect on it, then I think, well, geez, that's what you're asking. Like, who's going to be most effective at working to get this incentive? Well, people who are kind of effective at working towards incentives, you know. So that's kind of how it works, and I find it helpful in that it gets you to think about these things a little differently. People make choices about using drugs, the kind of stuff John was talking about. It just forces you to think through some things. So I think the incentive program, I'm sure it's some, like, depending on how we're defining motivation, it's helping to motivate people, but I think it's more like providing a concrete, short-term, positive reinforcer of the same, like, it's going to affect the same brain centers as smoking does. Right here, if you make this choice versus that choice, boom, you get